medication cost savings from the utilization of the medications and the overall, I don't want to say burden, but the overall care of the patient in the hospital. In conclusion, we found that there's enhanced patient safety outcomes with opiate-free anesthesia and adequate pain control given certain settings. I did list in the key findings a couple of procedures that stood out to us. They included colectomy, cesarean sections, and cholecystectomies. And with that, if there's any questions.
You may have gone through this, but could you tell me, I'm assuming it's Dex, but I'm not sure what agents were used most often in your review.
Dexmedetomidine was the one that came up most in the sources that we used, or that we pulled in the review. But ketamine did also come up a couple times as well.
Okay, and the regimen obviously changed based on the procedure and the length of the time.
It did, given the certain ones that they were indicated for.
And what common regional techniques were used?
I'm trying to remember.
Like tap blocks, truncal blocks. Probably not epidurals.
I'm trying to remember. I think maybe tap blocks were standing out, but I would have to get back to you. If you can leave your email with me, and I can get back to you.
And I guess my other question is: was there a difference between, or did you look at the different procedures in terms of ones that included multimodal as well as a general anesthetic, or ones that were done under solely spinal, or ones that were done under specifically peripheral nerve block?
Peripheral nerve block.
Okay, mainly.
Yeah, we didn't look at any spinal
Okay.
ones, spinal cases.
One last question. And
Yes.
you mentioned if it was a laparoscopic procedure, you guys found that less opioids were used?
And the opiate-free regimens were more effective in those procedures, in the laparoscopic ones.
Okay.
I just had one question as well. Of the other agents that were used for opiate-free anesthesia, besides for regional, and you mentioned dexmedetomidine and ketamine, did it go through any other agents at all?
No, just ketamine, and then they were mostly compared to fentanyl.
Okay, because we do a lot of spine surgery at my institution, and different multimodal things that we've been using besides for dex and ketamine, magnesium, sometimes beta blockers, sometimes running IV lidocaine. So that stuff can help as well. Thank you so much.
Thank you.
Audience, give them a big hand. All right, our next poster presentation is a scientific investigation entitled Cervical Peripheral Nerve Stimulation for Treating Headaches. This will be presented by Clara Nemmer, a student from University of Wisconsin School of Medicine and Public Health. So Clara, come up and we'll listen to your presentation.
Hi everyone, good morning. My name is Clara Nemmer. I'm a second-year medical student at Chicago College of Osteopathic Medicine. I just happen to do research at the University of Wisconsin where I went to undergrad. So occipital neuralgia is a common type of neuropathic pain caused by damage to the occipital nerve and its branches, so the greater, lesser, and the third. It presents with severe headaches and axial neck pain and is often resistant to medical interventions, pain medications. So on the other hand, peripheral nerve stimulation provides an alternative route whereby electrical stimulation is sent to the nerves by a stimulator lead and an external transmitter. And this external transmitter is worn by the patient, and it sends signals to the lead located near the nerve to interfere with the pain signals. So we present a case series of 4 patients who underwent this implementation after being diagnosed with occipital neuralgia. They were not experiencing decreased pain with pain medications, and it was really impacting their lifestyle. So medical records were collected for patients who underwent the implementation of the Freedom PNS system. And this data was collected, like these patients underwent these procedures between September 24th, 2020 and all the way through March 23rd, 2023. So the target was identified to be at the level of the C2 spinous process, and the high frequency that was used was 1499 hertz, and this is preset by Freedom PNS, and that's like the frequency that they have assumed is the most effective. So the patients were 3 females and 1 male, and they had an average age of about 57. They reported their pain score on the visual analog scale before the procedure, before they had the implantation done, and their average score was about 8.5. And I know it's a little bit small, but the different pain scores are in that table at the bottom. So after the implementation, they had a score of 3 after the trial procedure, and then we also measured pain scores 1 year after, and the average score even went down a little bit further to 2.125. So we did a paired t-test, and at a p level of 0.001, and the difference in pain scores was statistically significant. So the difference between pre-peripheral nerve stimulation, after, and then 1 year post-op. So this just shows that wireless peripheral nerve stimulation should be strongly considered as a highly effective treatment for peripheral neuralgias, especially in patients with occipital neuralgia. It has been used in the past to treat chemotherapy-induced headaches, and is now getting a lot of traction with peripheral neuralgias. The advantages of wireless neuromodulation is that it's minimally invasive. It includes the absence of the implantable battery. So this is why the wireless really works well with patients. It eliminates further surgical complications and challenging placements. It has limited side effects. So this curbs opioid misuse in patients seen with this type of neuralgia. And lastly, it exhibits sustained effectiveness during long-term follow-up. Occipital blocks have been used to treat occipital neuralgias before, but they are pretty short-term lived, and they have a failure rate of about 16%. Further studies should involve large sample sizes and to warrant, to increase evidence. So yeah, this case series just adds the growing evidence that wireless PNS is a safe and promising option for patients experiencing occipital neuralgias. Thank you.
Questions from the audience?
Well, I have one. You probably went through this, and I was messing with the timer. So, how long is this a continuous stimulation, or do you turn it on for a time period,
Yeah,
turn it off?
absolutely. So the patient controls the stimulation on their phone. So it's via an app, and they can whenever they are the ones that are administering the stimulation. So it's the lead is surgically implanted. They're wearing the antenna, and then with their phone, it's wireless. So
So they just turn it on when they need it?
when they
How
need
long
it.
did they usually leave it on before they get relief, or was that not been able to figure it out?
I'm not sure about that. Sorry.
And do we know how long the pain, when they did a stimulation, they got better, turned it off, how long did that last after they turned it off, that they would need to start again?
About a couple hours.
Okay.
Yeah.
And the battery lasts a while?
Yeah. So there's no battery involved. So yeah. So it's the antenna is what transmits to
Oh,
the
I
lead.
see.
Yeah.
Okay. So it's a good,
It's a wireless. Yeah.
Does this have to be adjusted for another surgical procedure as far as electrocautery and things like that?
I'm not sure.
Okay.
Yeah.
I mean, nerve stimulators and things like that, there are issues with electrocautery interfering and can change the programming of them. So I just was wondering if there was any issue with this.
Yeah, no, I'd have to do more research about
We
it.
would
Yeah.
have to look at that, yeah. Any other questions?
Just about the quality of the headache before. Were they mainly tension type headaches or migraines that they were experiencing?
They were both. So most
Okay.
patients experience tension type headaches and migraines as well. It was affecting their lifestyle. So I'm assuming migraines were definitely a part of it as well.
And then did you notice any difference in terms of relief if the patient had a migraine versus a tension headache, or similar?
We did not
Okay.
control for that.
Yeah.
Sorry.
All right, thank you so much.
Thank you.
All right, the next poster is a complex case, and it is entitled Delayed Malignant Hyperthermia Presentation in the Post-Anesthesia Care Unit. This will be presented by Tyler Patton, who's a student from Arizona College of Osteopathic Medicine at Midwestern University.
Hi, everyone. Good morning. My name is Taylor Patton, and I'm a fourth-year medical student from the Arizona College of Osteopathic Medicine at Midwestern University. Our medically challenging case is entitled Delayed Malignant Hyperthermia Presentation in the Post-Anesthesia Care Unit. This poster presentation was created with the help of my fellow medical students as well as Dr. James Brown. Malignant hyperthermia is an autosomal dominant condition that can manifest either intraoperatively or postoperatively, usually as a result of the utilization of the depolarizing neuromuscular blocker succinylcholine, or also volatile anesthetics, usually halothane. As I'm sure many of us are familiar with MH from frequent testing on our medical licensing examinations as well as throughout medical school, it is a clinical vignette that physicians very rarely encounter in practice. In fact, the majority of anesthesiologists will often retire without ever having seen a single case of MH. Moving on to our case report, we have a 62-year-old male with a past medical history of COPD, diabetes mellitus, hypertension, presented for an elective robotic cholecystectomy for symptomatic cholelithiasis. Preoperatively, the patient was determined to have no personal or familial history of adverse reactions to anesthesia. Patient was induced with lidocaine, rocuronium, and propofol. Sevoflurane was given for maintenance, and the surgical course was ultimately unremarkable. In PACU, 1 hour after the completion of the operation, our patient developed acute dyspnea with a respiratory rate of 42, sinus tachycardia, hypertension, hypoxia, and became rapidly febrile from 37 to 40.3 degrees Celsius in a matter of minutes. An A-line was placed as the patient continued to experience generalized tremulousness and muscular rigidity. Patient was reintubated with etomidate and rocuronium and found to be acidotic on BMP, hyperkalemic at 5.3, and hypocalcemic at 4.35. 3 doses of 100 milligrams of dantrolene were administered, and ice packs were placed on the patient, and at this time he did have improvement in hemodynamics as well as body temperature. Insulin, bicarb, and calcium were administered, and the patient was transferred to the ICU for further management, and he was ultimately discharged on day 5 without any significant deficits. And that table up there in the top middle illustrates our patient's arterial blood gas that was collected after the patient had blown off some CO2 from being tachypnic. So at this time, his only abnormal value was his arterial partial pressure of oxygen being 60.7 millimeters of mercury. However, his original BMP demonstrated respiratory acidosis with an elevated CO2. MH is a life threat that could be due to the inheritance of many possible mutations of the gene that encodes for the ryanodine receptor type 1 that ultimately results in excess calcium released from the sarcoplasmic reticulum upon exposure to a triggering anesthetic. With the rapid consumption of ATP, patients will typically present with hyperpyrexia, oxygen desaturation, tachycardia, muscular rigidity, hyperkalemia, and respiratory acidosis from the hypercarbia, even despite adequate ventilation. Once anaerobic metabolism ensues, metabolic acidosis will take over. If not recognized early and treated, patients can go on to develop multi-organ system failure such as DIC, acute renal failure, cardiac arrest. Treatment is with the ryanodine receptor antagonist dantrolene as well as cooling measures. Other focuses of therapy include managing their arrhythmias that can ensue, as well as hyperkalemia, which can be treated with insulin, beta agonists, Kayexalate, or calcium gluconate can stabilize the membranes of the cardiac myocytes as well. And then that figure down there in the bottom middle illustrates the release of calcium from the sarcoplasmic reticulum when there is a mutated receptor along with the triggering anesthetic, and that's that left box. And then the box on the very right shows the effective treatment with dantrolene, which antagonizes that receptor, preventing the release of excess calcium. While MH is already exceedingly rare, the delayed onset observed in our case, occurring an entire hour post-op, highlights the need for further research to determine the optimal duration for monitoring in PACU. These studies would help define how many hours anesthesiologists should remain vigilant for potential cases of MH. Some patients may not develop MH upon initial exposure to their triggering anesthetic, meaning it's possible that MH manifests after the patient has had general anesthesia multiple times without any complications. This is another topic for potential future research. Due to the lethality of MH, additional research is necessary to better understand both the occurrence and timing in a patient with no previous side effects from general anesthesia with volatile anesthetics. And if anyone has any questions, I'd be happy to take those now. Thank you so much.
Audience questions? I have a couple. First of all, audience, to make sure that you're awake. How many in the audience have ever had a patient that triggered MH? Okay, so it's not real common, as she said. I have a question about your diagnosis.
Yes.
Was this confirmed by a Halothane contracture test or anything like that?
It was not, to our knowledge. We did go back and look into that, and to our knowledge, they did not do a confirmatory test.
I understand that, because if a family member has an event like this and you get the test and it's positive, they can't ever get life insurance. So I understand
Okay.
you're not doing this, and so a reasonable approach is to treat everyone, first-degree relative or whatever, with a clean anesthetic.
Absolutely.
What other differential diagnoses would you have for this patient if it turned out it was not malignant hyperthermia?
I believe serotonin syndrome was considered as a potential option originally. They went through the patient's medical history, medications, and that was determined to obviously not be the case. I'm not sure what other differentials they had in mind. Those were the top two on the
Norlap malignant syndrome can also do
yes,
that as
yes,
well.
absolutely.
And even sepsis,
Okay.
because I had a case that we thought was septic, but turned out that it was MH, but
Okay.
similar. And your case, a lot of times people do not trigger with a halogenated agent till like towards the end of the case, whereas if succinylcholine is used, they trigger closer to like the timing of the succinylcholine. Anyone else have any questions?
This is just for my own knowledge, actually. When you were doing your literature search,
Yes.
what's the latest that you found delayed malignant hypothermia? Like 2 hours, 4 hours after a triggering anesthetic?
It's hard to remember. I don't remember seeing very many delayed presentations at all.
Right.
From my knowledge, normally it's very
Exactly.
immediate
Yep.
in the post-op area. So I don't have an
Okay.
exact time for you. I would have to get back to you on that.
Thank you.
Yeah, thank you.
We have a question in the audience.
Yes. If who was contacted, I'm sorry. I wrote about that in one of our bullet points, actually, because I didn't know that was a thing until I did my research. I don't know if anyone contacted them, because at that point I was probably gone. But yeah, that was interesting to find out about.
It's an important resource, M-House.
Definitely.
One of our Jefferson alumni, Dr. Henry Rosenberg, was involved in getting M-House and everything set up. And even if it is something that you're just not sure what it is, there's somebody on 24/7 that you can contact to run the case by them, and get their impression about what you should do. Because dantrolene is not without its side effects. It can cause a very significant phlebitis. It is a muscle relaxant in itself, so it can cause muscle weakness. And you don't want to label someone as MH if they're not, but you want to take every precaution if you don't have a definitive diagnosis. Any other questions? Thank you so much.
Thank you so much.
All right, our final poster presentation for this morning's session is entitled Massive Hemorrhage Following Celiac Plexus Block, and will be presented by Madeline Kinney, a student from Rocky Vista College Osteopathic Medicine.
Good morning. My name is Madeline Kinney, and I am from the College of Osteopathic Medicine in Colorado, Rocky Vista University, and we did a case report on a massive hemorrhage following a celiac plexus block, and it was with my mother, who is a physician at the Mayo Clinic in Minnesota. So this was a case that came to Mayo Clinic, a 61-year-old male who had presented with a ton of different comorbidities that made him very susceptible to bleeding. One of which was pancreatitis among myoblastic or acute myoblastic leukemia, myofibrosis, which obviously made him his bone marrow not as able to produce platelets as well as other red blood cells, white blood cells, and he also had cirrhosis as well as splenomegaly and chronic graft versus host disease, as well as stem cell transplant. He just had a lot of things going on that made him very susceptible to bleeding. And so he came to the pain clinic. This was a pain outpatient procedure performed by a very skilled clinician at Mayo Clinic. And it was a celiac plexus block that was performed underneath fluoroscopic guidance. And he had issues with, so again, just restarting, this was a 61-year-old male that presented to the pain clinic at Mayo. It was an outpatient procedure. He had a lot of pain due to pancreatitis. He had chronic cirrhosis, as well as splenomegaly.
Well, let's give her a round of applause.
A little bit about this case. We can summarize some of it because it was so good. Their patient was a 61-year-old man, had a history of, she said, myelofibrosis and leukemia, and and some chronic pancreatitis, and taking a lot of opiates for pain. He was offered this non-neurolytic celiac plexus block. He did have interstitial pancreatitis. We all know that that can cause a lot of friability in the abdominal organs. He had a very large spleen, 12.9 centimeters, and he had some ascites. Platelet count was okay. Hemoglobin was 9.8, and his INR was 1.2. He had the celiac plexus block in the prone position with some sedation, and they used fluoroscopy. And I'm not going to describe how it was done. I don't do them, but I know a lot of people know how to do them. They used 22 gauge, 5-inch spinal needles in the proper position, and they had negative aspiration. They used isohexatol contrast, and it confirmed the spread. So then 10 milliliters of bupivacaine, 0.5% with 1 to 200,000 epinephrine and dexamethasone, 5 milligrams, and 25 myclonidine was injected. Then the man in the following day had worsening abdominal pain and distension. He had vomited, and it was non-bloody emesis, and he fell. So what came first, the chicken or the egg here? He was seen in the emergency room 2 days later, and it was found that he had an intra-abdominal hemorrhage and hemorrhagic shock. Hemoglobin was 4.1. CT of the abdomen showed a large acute hematoma measuring 9.6 by 7.4 by 6.3 centimeters, associated with the greater curvature of the mid-body of the stomach, and there was a small amount of a punctate extravasation. They did note the cirrhosis of the liver. Blood transfusions were given, and he was transferred to the ICU. He had medical management for 5 weeks, and because he was such a poor candidate for surgery, in his 6th week he did undergo definitive surgery. There was a serosal tear in the stomach, and that was oversewn, and the abdomen was closed. His total transfusion over 6-week period was 59 units of blood products, 21 of packed cells, 3 of platelets, 30 of FFP, and 5 of pooled cryoprecipitate. So her discussion involves the potential for severe life-threatening hemorrhage following a celiac plexus block. We're always taught this. Most common thing that you see is hypotension when you do it, but there can be some long-term consequences. Hemorrhagic complications, are not common, and this gentleman had significant comorbidities that could have increased this procedural risk, which we saw. They are not sure whether an endoscopic ultrasound-guided celiac plexus block might have been any safer for this patient, but that, it sounds like, is an option. So I'm going to ask if anyone here that looked at this, of my moderators, had questions about this or things for the audience to think about.
I just wanted to say, as anesthesia providers or anesthesiologists, that we come across celiac plexus blocks with either under fluoroscopy and under pain management, or endoscopically when our patients are getting an EUS or even a combined ERCP. And more commonly, as we know, we see hypotension and sometimes diarrhea immediately following the procedure after their blocks. But you can certainly get massive hemorrhage if the wrong blood vessel is hit. And that's just something to keep in mind.
My other thought with this is maybe he was having symptoms of the block, may have had a little bleeding, but the fall didn't help things, and the fall may have contributed to that massive hematoma. We don't know that because he was someone that would bleed anyway, so it may not have been all on the celiac plexus block itself, although it may have been. But that was what my question was.
All right, well, that concludes this morning's breakfast session of the posters.